Today we will be discussing about our lower urinary tract symptoms. These are the symptoms which are more relevant to prostate, but there are other associated symptoms like dysuria, hematuria, and many other symptoms. So we can divide these symptoms related to the prostate into 7 components, and this is known as IPSS. You are required to remember these 7 symptoms. So these there is a mnemonic to remember these symptoms. So you can make it as fun and wise. So these fun symptoms, they indicate that if this is the bladder, so now the bladder cannot retain the urine. So there is failure to retain. So they are also known as irritative symptoms. And these next 4 symptoms, these are more concerned with obstruction. So prostate is lying over here. So once it puts pressure, so this passage is narrowed, urethra. So the urine cannot come out easily. So these are known as obstructive symptoms, and they are also known as failure to void. The patient cannot evacuate his urine. So these are 2 type of symptoms. The first symptoms, which are the irritative symptoms, or which are known as failure to retain. These are more common in different inflammatory conditions like if there is a UTIs, or if there is a stone. Okay, so these are more common in the situations once there is a stone or ureter or such inflammatory conditions. But the other symptoms, they are more common in obstructive situation. So I will just explain quickly about these symptoms, and then we will continue. So the only thing which is important in this today's discussion is you understand how these symptoms they develop.
Sorry, doctor. There's somebody want to join the lecture, so please accept them.
I was looking for somebody who wants to join. I cannot see anybody. There were some students I already admitted. Once anybody comes, I will again check. Okay, I will check after every few minutes. Okay, I have turned my control off, but let's see if there is anything. I will check again. So we were here. We were trying to understand that how these symptoms are produced. So I was telling you that suppose this is the urinary bladder. Here is the prostate, which is about 20 to 25 gram normal prostate. So this prostate, once it enlarges, it causes obstruction to the outflow of the urine. So the urine is normally coming. So in a normal person, the urine output is more than 15 ml per second. So this is the normal urine output. So the first symptom which a patient notice is the weak stream. So because of obstruction over here, the patient will tell you that I have a problem in passing urine. The flow, the caliber, the diameter of the my urine flow, my urine stream is poor. So it is not falling away. So you can ask the patient in your own words, or the patient can describe, but it indicates that there is a that there is a problem with the outflow. So this is an obstructive symptom, and you can ask the patient that the diameter or the stream of urine is the same as it was released or not. And the other way you can ask is, does your urine fall away or does it pass just near to your body? Because this stream, if it is good only, then the urine will fall away in a male patient. So the first symptom is the weak stream. So the urine, because of obstruction over here, it is just coming slowly, so it is not coming full. And if you measure this urine in a container and patient evacuates suppose 300 ml urine in say in 30 seconds, so it means his urine flow rate is
100 per 10 second.
10 ml per second. So it means it is 10 ml per second. So if the patient tells you that his urinary flow is poor, or the caliber has decreased, or there is a urine is not falling away, it means that there is a problem. But you can also measure this. So you can also measure such flow, and this is known as uroflowmetry. So if you measure this flow, then this is known as uroflowmetry, and this should be more than 15 ml per second. So once the pressure increases inside the bladder to overcome this obstruction, the bladder will gradually become hypertrophied and distended. So once it gets bigger and bigger, like dilated cardiomyopathy or gastric outlet, we already have discussed about gastric outlet
Doctor,
obstruction. Yes,
sorry for the
please.
interruption, but the share, I believe it's removed or it has gone, the share screen.
My screen is not shared with you.
Yes, unfortunately.
Thank you for letting me know. Is it shared?
Back. Yes, back again.
Okay.
Thank you.
So we let me check. Somebody's there. Okay. Nobody. So we were discussing that this is the key concept. If you understand this, then it will become very easy.
Doctor, I just stopped sharing again.
Okay, so we were discussing that the first symptom is usually the obstruction here, the benign prostatic enlargement. So there is an pressure over this point, and the bladder has to work more. So in the first symptom is the poor or weak stream of the urine. So this is the history part. But what we can do practically, we can also measure this flow. So this is the history point, but in the investigations, if I measure this flow rate, this is known as uroflowmetry. Uroflow. So urine flow is measured. So if it is normally it is more than 15 ml per second. So it means in 10 seconds the person should pass more than 150 ml of the urine. Now the second symptom, once I was giving you the example of the gastric outlet obstruction. So in the gastric outlet obstruction, the bladder, the stomach, if there is an obstruction at this level here, the stomach becomes very big like this, and the patient may have suction splash. Similarly, in the bladder will become bigger and bigger. So once the bladder becomes big, so to develop the pressure, to overcome this pressure or obstruction here, the bladder has to contract more. So there will be a delay in the start of micturition. In a normal person, when the bladder is of normal size, the urine flows quickly. But in a person in which there is a bladder outflow obstruction, because of the obstruction, the bladder is contracting more so that there is more pressure. So in this attempt, the bladder, it becomes gradually. So this is the normal bladder. But once there is an obstruction over here, the bladder will try to get more filled so that there is a more pressure. So once it becomes dilated and hypertrophied, the start of the urine will be delayed, and this is known as uh, so it is not here. Previously it was there, but then uh, there is a concept of hesitancy. It is not mentioned in this IPSS, but this is known as hesitancy, that there is a delay in the start of micturition. Anyway, once the pressure is built, the patient will be able to pass the urine. Now, after some time, this pressure will be lost. Then
Uh,
again, yes, please.
can we like classify the hesitancy with the intermittence?
No, no, that is different. I will explain. So
Oh,
once this bladder, no pressure has gone, so the urine flow will stop. Once the urine flow stops, the patient will keep on sitting in the toilet, in the commode, and then after 2 3 minutes, he will again take a deep breathe in, constrict his abdominal muscles and the bladder and everything, again develops the pressure to overcome the obstruction, and then he passes urine again. So he will be able to pass the urine not in one go. He will be able to pass the urine in 2 goes or 3 goes. So this break in passing urine is known as intermittency. So this is due to distended gallbladder. The first time it is known as hesitancy, but the second time once it stops and starts, then it is known as intermittency. And of course, he is continuously straining to overcome this obstruction. So this is the part of the same. And even at the end of passing the urine, the patient will be feeling my bladder is not completely empty. So this is known as incomplete emptying. So I have described to you the word wise, the mnemonic wise. So W stands for weak stream. It is due to obstruction, due to any there can be any reason. I will explain later. Now we consider prostate. So at the neck of the bladder there is a prostate, and it is causing obstruction. So this will decrease the urine flow. This is the patient will tell you. What you can do as a doctor, you can ask your team, or in the urologist OPD, there is a container and the patient is asked to widen that urine, and that is known as uroflowmetry. So with the word W, weak stream, you will remember one investigation. And what is that investigation?
Euroflowmetry.
Uroflowmetry. Then, because the bladder, like in the, if you see, if you want something like a rubber, the more you pull it and then release it, with more force it will come back. Same is the principle in the muscles, heart, fiber, bladder. So the bladder distends gradually more and more to develop more pressure. So it will, there will be delay in the start, and then in the middle the urine, once the pressure decreases, it will stop, and then again it will start. So patient will tell you, doctor, I cannot micturate in one go. I'm able to pass urine in 2 or 3 goes with a break in between. This is known as intermittency. So this is the I. Of course, the patient is training to develop the pressure at the time of micturition. So this is there. And the last is, okay, if you ask the patient, okay, once you pass your urine in total, do you feel that your bladder is empty? The patient will tell you, no, I feel still I have more urine to go, but I cannot pass. This is known as incompletely emptying. So E stands for emptying. So we can measure this W and we can measure this E. What is the name of the investigation for E? Incomplete emptying. We call it residual urine. Residual urine. So what is the meaning of residual? What leaves behind? In a normal person, there should be no urine, but if it is more than 100 ml, then it becomes very significant. So if a patient comes to us and we take a history about the W and I and S and E, so out of 20 marks here, we will give him marks and 15 marks for frequency, urgency, and nocturia. So total are 35 marks. You can see in this. So E means incomplete emptying, and the investigation to see the uh, incomplete emptying. Please just try to understand this concept, because your everything will be based on this concept. So this is the bladder. So the first symptom we said is the poor stream. This is due to obstruction at this level. Bladder will get distended, and there will be, patient has to strain to pass the urine, and there will be intermittency after weak stream, and at the end the patient will develop incomplete emptying. So it means after passing the urine, still there is a residual urine. So this residual urine can be measured. One way of measuring the residual urine is to pass a Foley's catheter after patient empties his bladder. So whatever urine comes on catheterization, that will be the residual urine. This is the one way. Other way is we send the patient to a sonologist, and the sonologist will measure the prostate size. This is the prostate over here, bladder wall, and he will, with full bladder, then he will ask the patient to empty his bladder and come to him again. So second time, once the patient goes to the sonologist after passing the urine, he then measures the amount of urine in the bladder, and that is known as the residual urine. So the ultrasonologist will have to perform the scan 2 times. First for the prostate and other things, and then for the residual urine. So this is the concept of the residual urine or incomplete emptying. Is this point clear?
Yes, doctor.
Okay, if now there is a suppose 100 or 150 ml residual urine. So if there is a residual urine, it will become infected, because anything which stays, either it is in the CBD, either it is in the gallbladder, either it is wherever there is a stasis, there is infection. So this urine will become infected. So in every patient who presents to us with Luts, we will suppose that the patient has UTI, because there is more residual urine. So that patient, we will see his urine for pus cells, microorganisms, and we will also do the culture and sensitivity for the urine to look for microorganisms present in the urine. And similarly, because the ureter is opening over here on both sides in the trigone, So there can be back pressure changes on the kidney. So the urea and creatinine may be abnormal. So that can also be affected. So we will also do the kidney function test. So this is the basic concept. So I hope you understand, and inshallah on this basis we will solve all the issues today. So can somebody read this scenario, please?
An 81-year-old man present to the emergency department complain of difficulty passing urine. On a questioning, he reports worsening urinary stream over the past 6 months, together with increased nocturia. This is a recent history of bedwetting. He has no pain. He opened his bowel 3 to 4 times a week, and his last bowel motion was 2 days ago. He is insulin for type 1 diabetes. He also take aspirin and simvastatin. He lies alone. He lives alone and mobilized well with a walking stick. He is a non-smoker and has the occasional whiskey at night to help him sleep.
So what is the presenting complaint in this patient? So patient has
Lower
lower
urinary tract.
urinary tract symptoms, and one of them is difficulty in passing urine, and he has a worsening urinary stream. So we have discussed the word fun wise. So in this scenario, they have mentioned the nocturia, and there is a weak stream. But there is also history of bed wetting. We will explain it later on. Okay. So in both sexes, there are non-specific symptoms of bladder dysfunction. Uh, and with age, of course, they become more. So not all symptoms of the disturbed voiding in aging men should therefore be attributed to bladder outflow obstruction due to prostate. So there can be age-related problems as well. So the urologists prefer the term Luts and discourage the use of the descriptive term prostatism. This was used before. So, in addition to the bladder outflow obstruction due to prostate or other reasons, the patient may have detrusor overactivity due to the age, diabetes, or idiopathic. It may be neuropathic bladder dysfunction as a result of diabetes, stroke, Alzheimer, Parkinson disease, and this can give rise to neurogenic bladder, and there can be blood outflow obstruction due to. So there can be overactivity, there can be underactivity. So the detrusor can bring many problems. So we need to consider, because one of the treatments is surgical. So if we do surgery on a wrong patient, it may be a problem. So I will just remind you of what we discussed for the stomach. In the stomach, we said if there is an ulcer on the anterior and posterior walls and that heals, it can cause a healed ulcer, which is also called a kissing ulcer. Once it heals, it can cause gastric outlet obstruction. Similarly, if there is a tumor of the stomach towards this end, so it can also cause gastric outlet obstruction. And similarly, here in the C of the duodenum, if there is a carcinoma of the head of pancreas, it can also cause the duodenal obstruction, and it is similar to the gastric outlet. Similarly, chronic pancreatitis, even it can cause this distortion of the duodenum. But the more important is carcinoma. Similarly, there can be annular pancreas and other conditions which can be responsible for gastric outlet obstruction like features. So similarly, here in case of the bladder, so there is prostate. So the what are the possible prostate problems? One is the benign prostatic hyperplasia. So benign prostatic hyperplasia can be problem. Similarly, there can be prostate cancer. So this is the prostate. Prostate can have either a benign enlargement or it can have the malignant enlargement. Now it is sitting on urethra, and sometimes the patients who have extramarital relationships, multiple sexual partners, they have UTIs, or we call it STDs, sexually transmitted diseases. So they can develop the urethral stricture. So that can also be a reason for the bladder outflow obstruction. So we have two causes related to prostate, and third cause we have said it is related to the urethra. So then there can be the bladder neck problems. So it can be bladder neck stenosis or bladder neck hypertrophy. So these are the 5 causes mentioned in your book as a cause of bladder outflow obstruction. 2 of them are related to prostate, that is the benign and malignant. 2 of them they are related to bladder neck. This is the bladder neck, this point. And 1 cause is related to the urethra, and that is the urethral stricture. And so if you are going to diagnose the bladder outflow obstruction, like gastric outflow obstruction, or there is a CVD obstruction, suppose here, or ureteric, or any obstruction. So we can diagnose, or like in esophagus, there is achalasia and pseudoachalasia. So we can say, yes, there is obstruction to bladder outflow, but we cannot say by surety it is always that due to, is it a bladder neck stenosis, is it bladder neck hypertrophy, is it benign prostatic enlargement, urethral stricture. So for that, so one first challenge is to prove it is bladder outflow obstruction, and the second challenge is to prove it is due to the benign prostatic enlargement, which is age-related problem and most common cause. So just at this point, before we do any surgery on the prostate, we always perform cystoscopy as a must to rule out any urethral stricture. And of course, TURP is done through the urethra. And then before we remove the prostate at the time of surgery, we also look into the bladder neck if there is any stenosis or hypertrophy. So other causes they are ruled out at the time of surgery if they are not done before. So, but the problem which remains is the neuropathic conditions. So this is not, and this may indicate a bladder outflow obstruction, but actually it is not the bladder outflow obstruction. So up till now we have discussed that there can be 2 problems in the prostate, benign and malignant, 2 problems in the neck of the bladder, and 1 problem in the urethra. That can be urethral stricture. So all these problems, all this area, this is known as bladder outflow area. So there can be bladder outflow obstruction, like we discussed for the stomach. But sometimes the problem, there is no obstruction, but the bladder itself is not contracting well. Suppose this patient is having type 1 diabetes, Parkinson disease, certain drugs. So if the bladder is not contracting, it will also present with Luts. So if the bladder is not contracting, how to look for this problem? If we measure the intravesical pressure in a patient with bladder outflow obstruction, the pressure will be high or low?
Low.
If there is obstruction in the bladder outflow area, neck, so what the bladder will try to overcome this obstruction?
High.
High. So bladder will contract so that any obstruction, and the person will strain so that if there is any obstruction, he is able to pass the urine. So if we measure the intravesical pressure in a patient with bladder outflow obstruction, the intravesical pressure will be very high. Normally it is less than 60 millimeter mercury. But if it is more than 80 millimeter mercury, it is too high. So this pressure in certain patients where there is a functional obstruction, you may perform the urodynamic studies by measuring the intravesical pressure. So name of the investigation is urodynamic studies. So you have uroflowmetry in every patient with Luts, but urodynamic studies will be performed in those patients where there is a doubt of neurogenic bladder. So the urodynamic studies, like you perform manometry in ecclesia to see the pressure in the esophagus, it is the same. Like you have this acute obstruction of the colon or Ogilvy syndrome. There is no obstruction, but there is a functional obstruction. So it is the same story. There is a problem with the contraction of the urinary bladder, and if you measure the intravesical pressure, so you may avoid any damage to the patient. So this is the key concept for this. So urine flow rate for more than 200 ml. So more normal person, it should be more than 15, and if it is less than 10, it is very low. And the voiding pressure in a normal person is less than 60, but if it is more than 80, it is high. So in a patient who has the bladder outflow obstruction too much, his urine flow rate may be less than 10, and his intravesical pressure will be more than 80. So the long term, the bladder may decompensate. So this we were discussing, that in the beginning there is a hesitancy, intermittency, but with the gradual passage of time, the bladder may become more irritable, and there is a decrease in the functional capacity on one side, but on the other hand, the bladder may become chronically distended, so there can be overflow incontinence, like in this patient. And in the beginning, there was increase in the residual urine. This is here. On the other hand, in some patients, it may become more irritable. So there is a problem with frequency, urgency, and there is a decrease. But if you see the residual urine component, it increases and increases, then the bladder may not contract at all. So the bladder is full. Now, whatever urine forms from the kidney, so it will continuously coming out. So there can be acute urinary retention due to the bladder outflow obstruction. But if there is a very big bladder and there is a continuously bedwetting, the patient is passing urine continuously with that big bladder. This is known as overflow incontinence. Overflow incontinence. So in this patient, because there is a bedwetting and there are Luts, so we are thinking of a complication, which is the urinary retention with overflow incontinence. Now the complications, I told you, one is acute retention of the urine. Patient is not able to pass the urine, but it is very painful, and patient will have a lower abdominal mass, which is bladder. Chronic retention, like this patient, in the beginning there is increase in the residual urine, and then gradually even contractility is lost and the patient develops retention of the urine. There is no pain because there is no contraction. Stretch sensation has gone, so the patient develops a very big bladder containing like 1 liter of the urine, and there is overflow incontinence like in this patient. There can be impaired bladder emptying and hematuria. If there is a hematuria in a patient with bladder benign prostatic enlargement, usually it is terminal hematuria. Other than pain from retention, pain is not a symptom of the benign bladder outflow obstruction, and its presence should prompt the exclusion of acute retention, urinary tract infection, stone, or carcinoma. So in this patient, we already know the history. He has Luts, weak stream, and there is nocturia. Now, in this patient, on examination, there is a palpable suprapubic mass, which is non-tender and dull to percussion. So, if there is a suprapubic mass in a patient with Luts, so this is the umbilicus, and now there is a mass in this area. What it can be? If it is non-tender and dull to percussion. Dull to percussion mean is it air or solid or it is liquid?
Solid.
Liquid.
It is liquid. So what is the liquid possibility here in the lower abdomen?
Urine.
Urinary bladder. So if you see here, one complication is acute retention, and acute retention is always painful. It
Painful.
is a painful situation. And it is acute, but chronic retention like chronic cholecystitis and other things, it is not inflammatory, by the way. So chronic retention, there is no contraction of the bladder muscle, and the bladder is very big, and there is overflow incontinence. And DRE reveals an enlarged smooth feeling prostate gland. So now it gives us the possibility that this outflow obstruction is due to prostate gland. We have discussed 5 causes of the bladder outflow obstruction. 2 of them were in the prostate, 2 were in the bladder neck, and 1 was in the urethra. What were the causes in the prostate? Anybody remembers?
BPH and
BP. So it is
prostatic
benign
cancer.
and malignant. One cause is benign, one cause is malignant. And in the neck of the bladder, it is bladder neck contraction or hyper, yes, and the urethral stricture. So these are the causes. Now these are the investigations in the urine. Potassium is high and urea is 20. Is it normal? Creatinine is 334.
No,
So
No.
it is too high. So it indicates that this bladder, there are the kidneys over here. So the kidneys are draining the urine against increase intravesical pressure, and this pressure is affecting the kidneys. Back pressure changes, causing renal compromise. So this patient is having the back pressure, renal changes, and this is the reason for high potassium as well. So we have discussed today the IPSS. This is the International Prostate Scoring System. If a patient comes to you with LUTS, the first symptom is the weak stream. So over the past month, how often you had a weak urinary stream? This is the first question, and it is indicating that there is a bladder outflow obstruction. The second question is intermittency. So over the past month, how often you have found you stopped and start? And I have explained to you why it stop and start. Because the bladder becomes very big, distended. So this is the reason there is a start in the delay, that is known as hesitancy, and then in the middle it stop and start, sorry, several times when, so this is intermittency. S is for straining. Over the past month, how often you have had to push or strain to begin urination? Just one point of caution over here. Sometimes the patient will tell you, doctor, if I strain, my urine flow rate decreases. Is it possible? This is the
Yes.
prostate over here. So in a normal person, whatever the cause of obstruction, if there is an increase in the pressure, the flow rate should increase. The stream should get better with straining. But sometimes there is 2 lateral lobes of prostate, and there is a median lobe of the prostate which is hanging in the bladder. So if the patient strain, this lobe may come in front of this urethral opening. So the flow actually may decrease. If the flow decreases on straining, this is a sure sign that the patient has benign prostatic enlargement or hypertrophy, hyperplasia. So straining, if it causes a decrease in the urinary stream, if then it is a sure sign of benign prostatic enlargement, indicating that there is a median or lateral lobes in the bladder, because these lobes are hanging in the bladder. But in a patient, in a normal patient who has a prostate enlargement or whatever, if the patient strains, the urine stream should increase. Other five, three symptoms frequency, sorry, the last is the incomplete emptying. So, how often you have had a sensation of not emptying your bladder completely? So, with the word wise or weak stream, what investigation I told you?
Urethrophotometry.
Uroflowmetry, very good. So, uroflowmetry, and normal urine flow rate is more than
10 milliliter
15
seconds.
ml per second. Then, with the last incomplete emptying, I told you one investigation which is must do, that is the residual urine. So, if it is more than 100 ml, it is significant. And then I told you this residual urine is a source of infection. Once there is a stasis, the patient will develop UTI. So you look for infection and other things. And these are the nocturia, this is something separate. So this is the prostate, which is hypertrophied, and this is the bladder. So you already know that carcinoma of the prostate develops in peripheral zone. So here in the yellow, even if somebody removes this transitional zone due to prostate enlargement, so if you see periurethral transitional zone, which is the place of benign prostatic hyperplasia, so even if you remove this zone, still the patient can develop a carcinoma. So sometimes the people may ask you, a patient has a history of prostatectomy, TURP, so can he develop carcinoma? Yes, because you only remove this part, transitional zone, and the carcinoma develops in this yellow colored zone. So this is sometimes asked. Coming to the digital rectal examination, as we have seen in this patient, that the prostate consistency will be firm, presence of a median sulcus, and there is you have seen, I think, the models in the skill lab. Presence of nodules within the prostate, this can be a suspicious thing, and similarly the fixity, and so you should know what are the indicators for carcinoma of the prostate. If the anal tone is very low, suppose the patient anal sphincter is not working, what will come to your mind regarding the prostate or Luts? The patient has
Magnet.
a neurogenic bladder. So then you must perform, if there is anal tone probe, it means the sphincter is not functioning. So it can be a neurogenic or neurological bladder. So you must perform the urodynamic studies before you go for any surgery. So hard gland and loss of contour and loss of median sulcus, palpable nodule and fixed, these are the indications for a carcinoma. This is the examination of the nervous system to rule out any issues. So if there is a suspicious, then you perform the pressure flow urodynamic study. So actually it is the pressure studies like manometry there in the esophagus. So this is known as urodynamic study. This is the must investigations. I told you, number one, I told you about urine flow rate. This is number one. Number two, I told you residual urine measurement. Then I told you, because this residual urine is a source of stasis and infection, so you should do urine analysis for any infection. And because if there is a retention, there can be back pressure changes, and you should measure serum creatinine. If there is a doubt about the neurogenic bladder, then you will do the pressure flow studies or urodynamic studies. And if there is any suspicious about malignancy, then you will perform the PSC level. So you should know essential investigations one, two, three, four, five, and you should know these two investigations which are additional when to perform these investigations. Is this point clear to everybody?
Doctor, I have a question, please.
Yeah, please.
Prostate specific antigen, what is the indication to do it? يعني بس if we suspect prostate cancer, we can do it only, or there is any other indication?
If you think there is a prostate cancer due to any reason, suppose on DRE the gland is hard, suppose there is a loss of normal contour, craggy prostate, suppose there is a loss of median sulcus, palpable nodules, patient has backache, alkaline phosphatase is high, indicating METs. So if you have any suspicious of prostate cancer, then, but by the way, nowadays there is a campaign to have the PSA in every man after 50 years of age. But it is not adding too much to the treatment. I will not go in this side because it will take a lot of time. But yes, if indicated, and I have given you the indications on DRE and other possibility of the METs. So this is about the pressure flow urodynamic studies, and if there is a neuropathic bladder like Parkinson's and other things, similarly diabetes mellitus, long-standing diabetes, then you need to measure if there is a irritative symptoms. Irritative symptoms are frequency, urgency, and doubtful history are flow rates are near normal, and if the urine flow is less than 200 ml for that. So invalid flow rate. What is invalid flow rate? Low voided urine. This is a video I will share with you. You can see it later on about how to perform the urodynamic studies. So about the management, just I will give you 2-3 lines because the time is less. So please remember, any patient with acute retention, this is a complication. This is a complication. So patient should have a definitive treatment, usually the TURP. Chronic retention and renal impairment. Similarly, if the post-void residual urine of 200 ml or more and raised blood urea, this is the chronic retention. So acute retention, chronic retention. Similarly, the complications are like stone, infection, and diverticulum formation. So in the stone, you will see, suppose there is a patient 50 years old or 65 years old male, he has a stone in the bladder. So we will ask you what is the treatment. So please, the question for such a patient is, if there is a stone, if you just remove the stone and you do not treat the bladder outflow obstruction, the stone will form again. So actual question we ask from you as a student is that what to do with the stone. So the correct answer is remove the stone with removal of the underlying pathology. Whatever is the underlying problem, like bladder outflow due to prostate or urethral stricture or bladder neck, whatever. So please always treat the boo and the stone together. If you just treat the stone but the boo is there, the stone will come back. And same is true for the infection and other things. Because if there is a residual urine, the infection will be there. Hemorrhage, and this is the a kind of emergency situations. And then we have elective prostatectomy, severe symptoms. So if it is 20 to 35, low rate less than 10 ml per second, and if there is a residual urine. So if you just remember, this is 10, this is 10 and 0, and severe symptoms, I'll say make it 20 or more. So this all are the indications for prostatectomy. Just to make you remember. Is it clear? So urine more than 100 and the flow rate less than 10, and the severe symptoms which is like 20 to 35, they are indications for surgical treatment. Holmium laser enucleation. So laser treatment or open prostatectomy should be considered if it is more than 100 gram. So again there is a 1-0. So what is the indication for HOLEP or laser treatment or open surgery? More than 100 gram. What is the indication for prostatectomy, severe symptoms, flow rate less than 10? So this is about 10 or 100. So just to remember. Now coming to the indications for elective treatment other than those previously mentioned. So if there is a symptoms like more moderate symptoms and the flow rate is 10 to 10 ml, but it is more than 10, and the residual and so then you may think about the prostatectomy in such patients because you have given a trial of the treatment, especially with large residual volume of the urine. So these are the options from your book. The first option is the watchful waiting, avoid the fluid at night. Is the drug therapy. So we start with alpha blockers, and we can add another alpha 5 alpha reductase inhibitors once the prostate is more than 35 gram. Previously it was 50 gram, but with this addition they have made it 35 gram. Sorry. This is the indication about that URP or the whole-up or open surgery. So conservative management, relatively mild symptoms, 0 to 7, reasonable flow rate more than 15 or 10, good bladder emptying less than 100, so you can wait. But if there is a severe symptoms, you may go. Regarding the drugs, improvement in maximum flow rate by about 2 ml per second. So more than placebo, and the results in a mild 20% improvement in symptom score. But TURP can increase the flow rate from 9 to 18 ml per second, and 75% improvement in the symptom score. This is the reason that the gold standard treatment nowadays is the TURP. So just to summarize, if the patient is having equivocal symptoms, you may have a watchful waiting. But if there is a development of the residual urine and the stream problems, you can start with alpha blocker. If prostate size is more than 35-40 grams, you can add 5 alpha reductase inhibitor. And if the symptoms are more severe or failed medical treatment, or there is a complication like infection, stone, diverticulum, retention of urine, severe symptoms, all these are indications for TURP. Just the last thing, you should remember the complications of TURP. So my colleagues may be waiting. Just the last slide. So once you go for surgery at this area in the prostate, so most of the times you may damage this internal urethral sphincter. So majority of the patients, like 40 or 50%, if they are sexually active, they may have retrograde ejaculation, so there may be problem with fertility in men. Similarly, you are doing surgery in a patient with increased residual urine, so there is a risk of UTI after surgery if it is not before. Similarly, if this sphincter, which is just here, the external urethral sphincter, which is have incontinence of urine, and such incontinence is known as total incontinence. Whatever urine comes from above, it will go out. There will be no bladder palpable because no sphincter is functioning, neither internal nor external. But this will not cause damage to the urinary tract, that is, the kidney will not be damaged in total incontinence. In overflow incontinence, yes, they are damaged. Similarly, there can be stricture of the urethra. There are other complications. So this is the few words about this concept of the bladder outflow obstruction and neurogenic bladder. So you should exclude the neurogenic bladder if there is a doubt due to the more irritative symptoms, or if there is other concerns like patient has a problem with the sphincter or S2, S4 cardiac area. So or Parkinson, certain medications. So if there is any doubt, you can go for urodynamic studies. But to prove the bladder outflow obstruction, you have to measure the urine flow rate, residual urine, and the IPSS. So you make your decision based upon IPSS. IPSS, you make your decision on the urine flow rate. Normal is more than 15, and residual urine. If there are complications, you always go for surgery. But you should know the complications of surgery. So if there is a high IPSS, like suppose I told you severe symptoms, urine flow rate less than 10, and residual urine more than 100 or 200, that is an indication for TURP. Below that, you can try the alpha blockers and 5-alpha reductase inhibitors. If you have any questions, you are welcome. No questions?
Thank you,
Only
Doctor.
Doctor.
Thank you very much, all of you.
Thank you, Doctor.